Good afternoon, everyone. So let's start. I hope everybody is now in a very good mood after a good lunch, a little bit sleepy. So yeah, you can take a nap if you need to. That's fine. So we will start a new symposium about psychopathology. And I will first talk in more theoretical way about evolutionary psychopathology, about some theoretical approaches, and then I will invite my two colleagues from the Institute of Psychiatry, who are actually the practitioners and clinicians who really work with psychopathologies, different types of psychopathologies. So yeah, and they will talk about well, actually many different topics. I think it's better to wait for their own presentation. So let's start. I will try to be quick because this topic is among my favorites, but it's not really my line of research. So I will present just quickly just a few points about evolutionary psychopathology because it's a broad area and there are many interesting topics. Of course, I won't talk about all of them. So why to study psychopathologies from the evolutionary point of view? Obviously, we have been already addressing several paradoxes, right? In the last symposium, our colleagues were talking about musicality, and they were also trying to explain why musicality actually exists, what are its functions, why is it some kind of puzzle for evolutionary thinking. And psychopathologies are also actually quite interesting topic because it is a puzzle for evolutionary thinking. In the Darwinian medicine, the central question is why we get sick, right? If natural, as some authors say, if natural selection is so powerful that it can shape bodies so perfect in so many respects, then why are our bodies also full of so many flaws and design oversights that leave us vulnerable to thousands of diseases? So that's the central question and paradox for Darwinian medicine in a broad sense. And specifically in Darwinian psychiatry or psychopathology, we ask the question why we get mad, right? Why we get psychologically sick. So how come that natural selection has not yet eliminated mental disorder genes if they have been around for thousands of years and if they simply crushed the reproductive success of their carriers? There is lots of evidence showing that there is some genetic basis of many different psychopathologies, and specifically the most severe ones, they decrease significantly individual survival and also reproductive success. So theoretically, they shouldn't exist, right? They should be actually eliminated from the gene pool. However, we know that psychopathologies are not rare. They are very frequent in the population, especially nowadays in the recent populations. Some recent data are showing that, for example, half of Americans have already suffered some kind of mental disease during their lifetime. In Brazil, we have already seen in the morning, in the other session, that people over here also suffer lots of mental diseases. Children, more than 13% of children already have some clinical psychiatric disorders, which is quite a lot. Sometimes people think that psychopathologies actually appear only in adult population, but obviously this is not true. And some data also show really high frequency of anxieties and depressions over here in Brazil. It seems that Brazilians are among the most depressed in the world, and they are probably the most anxious in the world. So it's almost or more than 9% of the population has clinical anxiety, which is a lot, right? That's a huge proportion of the population. And now I'm talking only about 2 specific examples of mental diseases. There are many more, of course. So it is interesting to think about psychopathologies from the evolutionary point of view, why they are here. Do they have any function? There are several evolutionary theoretical models trying to explain psychopathologies. Some of them, here I'm just showing some of the books. There is actually quite a lot of literature about evolutionary psychopathology and psychiatry specifically. So there are several main models. Some of them explain psychopathologies as a mismatch. Some of them explain them as a trade-off. I will try to show a little bit more afterwards. Some of them are trying to show that maybe at least some of the psychopathologies may be actually adaptive. And of course, there is the maladaptive or non-adaptive model suggesting that psychopathologies, at least the severe ones, are actually maladaptive. They have never been really adaptive. We might talk about many different examples, but schizophrenia is actually one of those most puzzling because it's defined by a specific mental state, by psychosis, which is described as difficulties determining what is real and what is not. And that's problematic, right? If for example, if I perceive the reality differently than it really is, I might be walking around and I might fall somewhere because I simply do not perceive the reality as it really is in front of me. So I would do the step and I might be injured, hardly. So not perceiving the reality does not really seem very adaptive. And there are lots of symptoms, right? Of course, there are many different types of schizophrenias, but the most cited symptoms would be social withdrawal, anhedonia, emotivation, social cognitive impairment, neurocognitive dysfunctions, deficits in working memory, processing speed, executive functions. So actually all the main cognitive functions are impaired in this specific state of mind. So of course the maladaptationist model would explain or would suggest that schizophrenia doesn't have any function, it has never had any function, or evolutionary function, right? Not even social function. There are several models also within this point of view. For example, the cancer model suggests that some diseases such as schizophrenia remain in the population because they appear after the reproductive period, right? And of course, schizophrenia has a strong genetic component. The problem with this, and there are many other diseases that actually appear, such as cancer, right? That appear mostly later in life when the individuals have already reproduced, so they have already passed their genes to the next generation. However, schizophrenia actually usually appears earlier during lifetime, and in many cases actually during adolescence. So this specific model doesn't seem to be very plausible about schizophrenia. Novelty model would suggest that accumulation of deleterious mutations take a long time to be removed from the genome by selection, so it can be simply a random evolutionary novel mutation, which actually doesn't have any possible adaptive function. And some authors actually show that sometimes evolutionary authors are trying to hunt the possible adaptive functions when there are actually none. So we should be careful about possible interpretations or explanations, evolutionary explanations. Then there is the trade-off model, which might which would suggest that many symptoms associated with schizophrenia, such as disordered thinking and delusions, could be viewed as outliers of a normal continuum of social behavior, creativity, linguistic skills, and other social abilities. So actually, in this point of view, schizophrenia actually would be a non-adaptive extreme of an adaptive continuum. Right? So everybody actually would have some degree of schizotypic features or characteristics that are actually adaptive, but if they pass some limit, then they wouldn't be adaptive anymore, which actually applies to many other behaviors, right? Usually when there is an extreme form of behavior, it's probably not very adaptive, although the other forms of the continuum might be quite adaptive. The adaptationist model suggests several possibilities how schizophrenic characteristics might actually be adaptive, either nowadays, but mostly in the ancestral times. For example, the shaman hypothesis suggests that some psychosis would be advantageous to shamans spearheading religious rituals. The group splitting hypothesis was quite interesting, suggested by Price and Stevens, suggesting that some specific schizotypal traits or characteristics in specific prominent individuals might actually help to divide social groups when the group actually grows too much and it needs to be divided. So a new leader is necessary. And here is, of course, there are many other possible models and theories and hypotheses about schizophrenia. I just brought you a few examples. Here, I actually came across a paper last week by Marcus Rantala and his team, who wrote a new paper, new analysis about possible evolutionary perspective or analysis of schizophrenia. And they were actually showing many possibilities, many theoretical models, such as those that I brought to you, that I showed you. And they actually show that which model is the most promising is the mismatch model, which means that schizophrenia might result actually because there is a specific mismatch between the nowadays style of living and the ancestral style of living. But they go on and they talk actually about many other factors that might influence schizophrenia. So they actually show a very interesting model of interactions of many different factors, such as chronic stress, which is very specific for the nowadays Occidental populations. They also show that schizophrenia is basically non-existent in hunter-gatherers, for example. They also show, or they discuss the genetic part, and they discuss the role of pathogens, which can actually directly influence some psychosis and also development of schizophrenia. So this is actually just a very, very recent paper that was published last week. And it's very interesting because it's showing actually different interactions between the internal biological factors, right, genetic factors, but also environment, and how all these can actually influence a trait so complex as schizophrenia, which is really difficult to explain from the evolutionary point of view. Then I would bring, as an anthropologist, of course, for me it's always interesting, the interdisciplinary and comparative approach. So when we are talking about psychopathologies and evolutionary and possible evolutionary explanations, I have always been thinking, so are there psychopathologies in other species? And obviously there are, right? I mean, if someone of you had a cat or a dog, you might have actually noticed that some behaviors are sometimes strange, right? Sometimes the individual can react differently than expected, more aggressively, or the opposite, right? Or the individual is not socializing with the other individuals, and this can actually be seen as pathological. Or, for example, self-grooming can be missing. And in zoos, this is actually quite obvious, right? There are some species which are actually very difficult to be maintained and in captivity, such as felines and also primates, actually. So they can actually show many symptoms which are very similar to anxieties, to depressions, and other mood disorders, eating disorders, right? Very often they have eating disorders. So yeah, there are definitely several psychopathologies that we share with other species, and also in other cultures. There, actually, during the last century, there were many attempts to show that some psychopathologies actually exist in other cultures, while others actually don't. And this is interesting, right? Sometimes it is possible to compare, to study the same characteristic or psychopathology in different populations, but sometimes, for example, as noticed down here, actually there are some local specific population psychopathologies which exist only in the given environment and only in the given culture. So this is also very interesting and rarely studied from the evolutionary point of view. And of course, what the evolutionary perspective is bringing is actually a philosophical question, right? What actually is normal? And for some person of the same symptom, the same characteristic can be completely normal part of everyday life. It wouldn't make any problem, it wouldn't create any problem in social life of the person, while exactly the same characteristic might be very problematic for another person. So even the diagnosis sometimes is quite subjective. What is important, and Randolph Nesse is talking about this very often when we are trying to analyze psychopathologies from the evolutionary perspective, we shouldn't forget that natural selection doesn't shape diseases. It shapes traits that makes us vulnerable to diseases. And that's the crucial difference, because sometimes some authors are trying to explain the disease, right, the symptoms, but they are actually a consequence, right, of the evolved mechanism. So, and some disorders such as anxieties and depressions, which I have already mentioned, are actually natural responses of hyperactivated threat detection system, right? So actually, what we should study is not really the symptom, but the mechanism that is leading to the symptom. From this perspective, a clinical major depression can be an extreme point of an adaptive continuum of low mood and low motivation state, right? So what is actually the unit of our evolutionary analysis is actually the mood, right? Or the mechanism of motivation, and not really the depression per se. And this is just to finish a small example of different ways of thinking, right? When we are thinking about psychopathologies from like naturalistic or biological perspective, then we are not really talking about what is normal or what is not normal. Usually we're talking about diversity, right? And about continuum, and not really dichotomy, which is, we are not really talking about that this individual is already sick and this is still healthy, but there is some kind of continuum, and we do not need to normalize. And sometimes actually what seems to be a bug can be actually a feature, and sometimes what we call a disorder or an illness or sickness can be actually some kind of strategy, which might be even adaptive for the given environment or specific condition. So the evolutionary perspective offers a viable approach to understanding psychopathologies, also sexual paraphilias and other relatively rare conditions. And that's basically it. Thank you very much for your attention. And I think that we will leave the discussion afterwards, right? We should maybe do the whole thing, the whole presentations, and then we will discuss in the end. So now I'll ask my dear colleague, Hermano Tavares, who will be presenting, if I can find it here, about actually his main domain, I think, which is the impulsivity, decision-making, and loss of control, a psychiatric perspective. So now you will hear the real psychiatrist, not an anthropologist, right? Thank you very much, Hermano, that you are here with us.
Thank you. Well, good afternoon. Thank you, Yorka, for your kind words. I want to thank you, and I want to thank Iago Moraes and the organizers of this meeting. I'm really, I'm really happy to be here and honored. I'm more of a curious person over evolution. I'm not a person that studies evolution, though I think it makes a lot of sense for at least part of psychiatry, for at least the part that I work with, which is behavioral addictions and impulse control disorders. So I want to talk a little bit about them to you today. So, but I have to start by saying that whatever I'm going to say now has this cultural and time perspective, right? We are living the postmodern era. What about the postmodern era? It's the era of abundance. Never, really never before in human history we had so many abundance of whatever you can think of. Let's say energy, a lot, like we never had before. Let's say food, let's say sex or sex opportunities. Let's say information, let's say just credit to acquire whatever you want, all of the things that I mentioned just before. We never had so much, so many. It's the time of plenty. We are a wealthy species, even though it should be recognized that we don't distribute our wealth properly, but we are still wealthy. You know, I'm just talking about Brazil. I'm talking about the whole human society, right? So, but wealthiness comes combined with technology. And technology mixes all together. Things that don't happen naturally will be put together so that we will have new products to ensure new behaviors, such as eating fast food, right? So, there's no way in nature that we will find French fries. French fries don't grow on trees, right? But they have it all. They have it all combined that will make it tasty, that will make it appealing to whoever is here. Think of those super processed foods. Think of French fries. Think of chocolate. I may ask you, who here doesn't like chocolate? doesn't like French fries for real? Oh, maybe one person will, me, I don't like French fries at all. I really don't like. But do you really dislike it? Like it's not tasteful when you put it on your mouth? It's impossible, come on. It's bright yellow. It's salty. It's crispy in the inside, moist and soft. It's crispy on the outside and moist and soft in the inside. It's perfect. It's the perfect food for your taste, not for your health. And it's meant for you to binge on it. It's meant for you to lose control over it. Make no mistake, chocolate, the Beast bar, is meant for you to lose control over it, right? And why is it so? Because it combines so many characteristics that shouldn't happen. What happened by nature naturally won't happen. And they will provide you a really, really potent dopamine release at the center of your reward, of your brain reward system. So the most pleasurable the food, the greater the dopamine release on your brain reward system. And this is also true for whatever sexual preference you might have when you log in on Pornhub or stuff like that. You will have delivered directly into you. No beating around the bush. No, not having to, you know, like give it a talk, invite for a dinner, and then pay for a very expensive wine. No need for that. Just log on, right? And people from marketing, publicity, retail, they know all about that. They know all about. So they will play on your keys. They will use the knowledge that we graciously provide to society for something that we didn't mean for. So, for example, this comes at the same, this comes at the same height of this. No, it's no coincidence. This will attract the human eye no matter your gender, right? Because it's instinct. And then when you look at this, then we will look at this as well, right? Well, this is another case that is that's quite different from the other one, because this is not an instinct. For you to know that this is an object of desire, you have to belong to the culture that will teach you that this is desirable. But not just that this is desirable, it also says it's a once-in-a-lifetime opportunity. Buy it now or you will miss it. Ooh, that per se will enhance my desire so much, right? So we've come to the point, so the real idea behind all of this is that we are living a mismatch, a timing mismatch. We have all those drives, we have all those behaviors carefully selected by Darwinian evolution, right? But we have changed our environment on a very, very faster pace. So there's a pace, there's a timing mismatch between the environment we have transformed and whatever we have had selected in our minds. So our minds work with the idea that we are still living in poverty, that whatever means for survival we have out there are really scarce and needed. Well, what we're living is quite the opposite. There's a lot of everything out there, and the problem is not how can I get it, it's how can I don't get it to the point that I will ruin my health. That's the point. So it's kind of unnatural. It's kind of, really unnatural. There's not a better word for this. You have to use your rationality to fight your instincts all the time. Because technological advances, the combination of information technology and telecommunication that you carry on your pocket will provide you with, it's really a bombardment with a continuous bombing of information about opportunities, about new products, products designed to appeal to your desire. Unprecedented access to credit for you to get those products, and then you have to work like hell to pay for them. And that gets the economy running, right? Oh yes, and you always have so little time to decide, so you don't give it too much thought. You just act. So this is why impulsivity is now a postmodern challenge. And how can I say this? The holy grail is control. You have to learn how to control yourself. So when you don't do it, we will say, oh, you're impulsive. Oh, you have an impulse control disorder, right? Or you have an addiction. So, but what about impulsivity? How can we define it? Well, we work with this generic definition, which is impulsivity is a disinhibition of behavior that is not best explained by a mood disorder. So we're not talking about bipolar disorder, just to be clear, right? So someone is disinhibited, but not because he's maniac, right? And there's also a constitutive predisposition. In other words, it's a personality trait. In other words, it's dimensional, it's continuous. So everybody here is impulsive. It's just that some of you are less impulsive and some of us are more impulsive. That's it. But also impulsivity is a dynamic phenomena. It's not just dimensional, it's multi-dimensional, right? It's actually, we say, from the negative side of impulsivity, we could say that impulsivity is when the brakes are not enough to deter the gas pedal, right? And because we're talking about humans, this is not just a simple a dual dynamic, right? We're talking about at least 5 dimensions. First dimension, on the brake side of life, negative emotions such as fear and anxiety are obvious brakes. Cognitive brakes such as attention, memory, planning, analyzing the situation so you can make a better decision. Social and moral brakes, which are based on empathy, tolerance towards others, and the building of a code of conduct that we call ethics will constrict the possibilities of answers, and it will deter most of your behavior if you function well, evidently. On the other side, on the gas pedal side of life, we have intense desires, we have urges, we have all of these impulses that will make us close to whatever we desire, right? Appetites, love. And we have another set of impulses, which are aggressive impulses, destructive ones that are most mentally to repel threat, and on a derivation, let's say an evolution of the original aggressive instinct, there's the possibility of using aggression to establish social dominance, environment and social dominance, right? So impulsivity really is when this will overcome this, either because this is too strong or because this is not strong enough, okay? So in clinical reality, we can see it mirrored in many conditions, such as affect instability will derive on what we know as borderline personality disorder, cluster B personality disorders, bipolar spectrum, so to speak. Cognition instability are well known as ADHD and other executive dysfunctions. Lack of empathy, antisocial personality disorder, and the psychopathy trait. Desire, all the craving-driven behaviors, such as substance use disorders and behavioral addictions in general. And aggression, Self-aggression, well recognized on non-suicidal self-injury and suicidal repetitive behaviors. And aggression directed towards others is best represented by intermittent explosive disorder, or the short fuse syndrome, right? So these are some examples of a dimensional impulsiveness model approach to psychiatric disorders. We call it the ACIDA model, and we've been working on it for the last 20 years. In another opportunity, I may dive a little bit deeper into that, right? But for the second part of this presentation, I want to present to direct your attention to this other idea, that is impulsivity or impulsiveness is equal to suboptimal decision making. It's all about making the best decisions, those that will lead you to wherever you want to go, or from an evolutionary point of view, for reproduction, right? Okay, survival and reproduction. Our decision-making capacity is tested every day. Well, it's lunchtime. Should I take pasta? Should I take salad? When this meeting ends, should I go home and binge on Netflix? Should I study a little bit? What should I do? Well, you know, inside your mind, inside your brain, you have two judges or two referees to help you make a decision, right? So this is a classic paradigm. Maybe most of you know about it. It's an ethic paradigm. And you say, you know what? You are a controller of a trolley, and you are located somewhere far, far away from this working site, where you have on the right side 5 workers. On the left side, you have 1 worker. Tell you what, the brakes on the trolley are lost, and you have a decision to make. You might as well do nothing and let luck take its turn, or you could decide, if you press the lever here, 1 guy will die, and you will save 5 of them. If you don't do nothing, probably 5 will die, and 1 will be alive. What will you do? And I'll leave it for you to think of. You have half an hour, okay? That's time enough. Oh, that's so much time. Couldn't I get there and save all the 6? No, you can't. There's no iPhone, unfortunately. You have to make a decision right now and wait for whatever comes. Okay? So we will take, you won't need really 30 minutes. You will say, oh boy, well, this is hell. Okay. I will kill 1 guy and save 5. That's the best thing I can do, given so slim possibilities that you're giving me. That's the more rational thing to do. So this is a rational decision. You will use your dorsolateral prefrontal cortex to take this kind of decision. On another situation, I won't give you so much time. First of all, I will say, you have to decide now. Another thing, I'm not going to put you so far away from the local side. I will say, you're just passing by. There's no time to tell the guys that something odd is going on. You just see here someone slightly fat, and you say, okay, if I throw him on the railroad, he will dislocate the trolley out of the rails, and I will save 5 people. So, make a decision right now. Will you push the guy out of the bridge? Will you kill him? And people are going, oh, come on, you're crazy. You shouldn't do stuff like that. This is horrible. Yeah, but if you take it rationally, it's still 1 for 5. Why won't you? Well, you won't. Really, really few people will say, yeah, why not? No, people will say stuff like that is really not rational, but I have to touch him, you know, like it's not really comfortable. Because you are reacting emotionally. And emotions are a second judge, or first judge, one is the other judge. that takes decision based on how would I feel if I were the one looking from the bridge. And if someone had the brilliant idea, oh, throw him out of the bridge. Why not? Right? So, and also emotion takes command when you don't have much time to decide. So you get at the so emotional is actually the automatic mode of your brain. So you don't have much time, you have to react fast and take a decision. Use your emotions. You have a lot of time, well, then take the time you have. Listen to your emotions, but be rational. So listen to both judges. So and that's it. When people are trying to make you decide their way, right? They are trying to manipulate you. They will tell you there's not much time to think of. It's buy it now, compre já, compre já. This opportunity, this offer, the sale will end will finish at the end of this advertisement. You have to decide now. Another thing is, don't think of all the possibilities. Don't think of the whole scenario. Just think of performing, man. You have to be the best. You have to make the best deal out of it. You can't miss it. It's really interesting. We have done this several times. We put people to take a simple test where they have to find a code. And the code will seize an aversive noise, such as the one we were hearing just before the presentation, right? So it's a really simple code, and we'll say, you know what, I don't know if there's a code, but you were supposed to stop it by clicking this, by finding the code and stopping it. To the other people, we will say, you're not supposed to produce anything, but we want you to tell us if there's a code that could control this. Well, oddly enough, people who are set to perform will perform worse than those who are set to analyze. So, less performance, please, people, and more thinking, more analysis. Yes, and enough with this Black Friday opportunity, and this is just for today, right? Because tomorrow we will renew our offer, evidently. But we will always make you think that this is a once-in-a-lifetime opportunity, really. And frustration is really, really interesting. Most people on what we say cold conditions will tell you, well, you know what? I don't know if this is a good deal or not. I'm going to try it. Yeah. And if I don't get what I want, I will just quit, right? When in reality, it's just the opposite that really happens. If you risk something like in gambling, and you don't get the expected results, you don't get the expected outcome, you get outraged, and you will double the investment. You will double the energy in search of this outcome that you were, well, idealizing about, really. So in other words, if you want to be a player, if you want to play whatever you want to play, whatever game you want to play, not just gambling, you have to accept that you might lose. In other words, you have to learn to be a gracious loser. We can't always be winners, all of us. It's good sometimes to lose. You will learn something from it. So, oh, I forgot to translate this. So, problems in decision making. How to make better decisions. Take the knife out of your throat. If people are telling you, you have to decide now, then think if you really have to decide now. Think if you don't have more time. And if you don't, search for more time. Buy time if you need. Even spending some money to buy you some time so you can make better decisions, right? Understanding where you are is necessary and comes before just performing or setting your mind into guaranteeing an outcome. Really, think that opportunity is quite different from your need. It's not because it's an opportunity that it's what you need. And this is really advice that I give to patients, right? And as I said before, learn to be a gracious loser. Well, thank you for your attention. And I was just, as I was saying, I was just thinking, this is a quite unpopular talk, right? Like, learn to be a loser. You don't have to be a leader. We don't want you to succeed. Well, you might as well understand it like a saying, you don't have to. It's not your obligation, really. I hope that this might take some lift out of your shoulders.
I really liked it. Thank you very much. And we'll invite, I'll try to help you with the presentation maybe. So, I would invite, I would invite Andrea Costa, who is actually also a clinical psychologist and psychiatrist. And we met actually at one of my courses, right? But now we are colleagues, which is great. And she will talk about her practice, her specific specialization and clinic about pathological love and pathological jealousy, which is definitely very interesting, and we are looking forward to it. It's your turn.
Thank you, Jaka. Well, I have the hard the moment now, right now after that presentation of yours. I'm in trouble, but let's go. I'm going to talk about everyone here in a moment, once in a lifetime, I guess, had a kick on the ass, right? Or felt very jealous about your partner. So it's about that we're going to talk about here, and how to treat that kind of patients when they get to your consultório, esqueci, office. Okay, let's talk about first about pathological love. What is pathological love? It's an emotion that is characterized by the repetitive behaviors trying to control your partner. So you want to control your partner, so you start to take care of them. So you don't take care of your partner because you are a nice guy or a nice woman. You take care of your partner because you want to control your partner. Eh? You want to know where he or she is, what he's doing, and she's thinking about you, not if they are really need to go to a doctor. You want to be part of his life or her life, and the kind of person with pathological love, they have high levels of impulsivity. So they try to, I'm not going to call my partner, I'm not going to take care of them, I'm going to take care of my life. Now it's my turn right now. But no, what he's doing, I guess he didn't eat a salad, eat a pasta. It's not healthy. I need to send a message and say, oh, did you eat well? Are you okay? Are you nervous? Are you quiet? So they are impulsive, and they need to send a lot of messages along of the day. And pathological love are associated with anxious ambivalent attachment styles, and mania and agape love styles. And what is this? Bowlby said to us that there are three types of attachments. The first one, security, consistent in parental and emotional available. Trust and safety is the more safe one. So if you have this kind of attachment, you are good in a relationship, you can support that your partner meets another person, not sexually, but have friends and the others. The second type of attachment is avoided, where there's a constant rejection, lack of trust, emotional unavailability, emotional self-sufficiency, and there's a lot of excessive jealousy too. Here, the person tends to think like this: no, I don't need anyone, I just want to give some kisses, take a one-night stand and then go away. But in the end, they want to be bonding with the others, okay? And the third one is anxious ambivalent, characterized by inconsistency in parental emotional availability, where their experience of abandonment and separation anxiety. So here we got the pathological love. And talking about the love styles that I talked here, that pathological love have mania and agape style. Lee is a research about love styles, and he says that there are 6 types of love styles. The healthy one is eros, feel physical attraction to the partner, and the most pathological one is mania, eros plus ludus, where the person is obsessed by the partner. There's a lot of jealousy, emotions, possessiveness. And ludus, it's one that appears sometimes in jealousy persons, where how can I say, it's a kind of love styles that the person wants to, like a game. I want to be with you, but I want to be with you, with the other one, I want just to conquistar, esqueci como fala, conquistar o parceiro. Conquer the partner, okay? So in our outpatients in the clinical hospitals, we studied the pathological love individuals, and we found that the most of them are women, 75%, the middle age is 40, and they do not live with formal love. It's an interesting find, because we thought that in some point this kind of person had a partner, but the partner has run away a long time ago. They don't want to stay with someone who wants to control them. In the psychiatric diagnoses that are accompanied with the pathological love, the most important are depression and generalized anxiety. It's important to note that almost 30% of them had a suicide ideation, but 22% don't have a psychiatric diagnosis. So the main characteristics of pathological love are they have less satisfaction in their relationship, but they have a great idealization of the relationship. We mean to be together, we're gonna live forever, like just the songs says, the romantic songs, like we mean forever, you know. And they have abnegation. I prefer to suffer instead of see my partner suffer. And there are some psychiatric disorders, like I said before, depression or anxiety. The second pathology of love is jealousy. We used to treat them in the clinical. And what is jealousy? It's a response to a real or imagined threat. It can function as a way of maintaining social cohesion in pair bonds. So jealousy can be an instrument to keep my partner inside of me. It works in the beginning, but in the end, well, the end can be catastrophic. We can see in the journals or the newspapers, a lot of men kill their partners when they didn't accept the finish of the relationship. So jealousy occurs due to the possibility of the reinforcement loss. It's a strong bond between partners, and it serves to protect against the potential loss of the partner. Like I said in the first moment, if I'm jealous, the partner stays with me. Then my partner doesn't go out with his friends, his colleagues, he stays home with me, but in the end he's sad and wants to run away from me. Okay? So what is excessive jealousy? It's an exaggerated, disproportionate, and uncontrolled reactions, constant suspicion about partner's infidelity. There's a lot of thoughts, what my partner is doing, who is working with him, so where and who. It's a lot of questions that are in the mind of the pathological jealousies. Involves physical or verbal aggressions, most of the time. Threats by real or imaginary rivals. It's a good point because there's no necessary. Sometimes the pathological jealous person can be jealous of a hobby, a work, not only by another person. Okay, and we used to treat the non-psychotic jealousy, because psychotic jealousy there's another treatment in our point of view. We studied the excessive jealous person, and here are the personality profile. They have a lot lower self-esteem, a lot of impulsiveness, bad social adjustment, and a lot of childhood trauma. They are so aggressive, they tend to yell, to kick. Okay, they are a lot of anxiety, and they are characterized by mania, love style, and anxious, ambivalent, and avoided attachment. But well, according to evolutionary psychology, you know well better than me, there are two types of jealousy: sexual jealousy, that are composed by suspicion of sexual betrayal if a third part, and emotional jealousy, that is suspicion of an emotional attachment to a third part. So we studied the difference between sexual and emotional jealousy in a sample of excessive jealousy, persons with excessive jealousy, and we find that, well, there are no difference regarding socio-demographics, but 87% of our total sample were heterosexual in our hospital, and the mean age 34, and it's a good thing, I guess, that almost half of the sample are living with their romantic partner. So if you want to have a love pathology, you have to choose to be a jealousy one, because your partner stay with you, and when you have pathological love, your partner runs away. Well, talking about psychiatry disorders, they used to use 31% of women sought treatment of mood disorders. Half of the total sample attempt suicide at least once. And it's important to note that 13% of men sought treatment for addictions. Okay. In the main comorbidities that women presented showed 31% showed mood disorders, 72% showed generalized anxiety, and 54% showed suicide attempts. Men didn't show these characteristics, only women. So we found that women had more problems with jealousy compared to men in our sample. Okay. The mean results says that men are characterized by eros and ludus. They are more attracted by the body, but they used to change the partners a lot more often than women. And they are persistent personality. It's a trait of personality, so they tend to persist in that behavior, jealous behavior. And they are more characterized by sexual jealousy. When we talk about women, they sought more treatment for mood disorder, showed more mood and anxiety disorders, they had emotional jealousy, avoidant attachment, more anxiety traits, poor self-directedness, less self-esteem, novelty-seeking, poor social adjustment, and sexual and emotional abuse history. So they are more, they present a clinical severe profiles. So we conclude that in our sample of patients with pathological jealousy, the difference between sexual and emotional jealousy remain in this kind of people. It seems that women experience more negative consequences due to psychiatric comorbidities, and ineffective response to jealousy can anticipate the termination of a relationship and understand the theological factors are key in the development of treatment strategies. So what we can do with the people when we get to our clinic? So how we treat the jealousy and pathological love? We treat the factors associated with it, that is depression and anxiety, impulsivity, the low self-esteem, need for control, relationship idealization, suicide attempts, and the lack of bonding, especially in the jealous person, because they didn't attach so well like the pathological lovers. Used two kinds of therapy, the psychodrama and the CBT, the cognitive behavior therapy. Psychodrama, we published an article a long time ago, but our group is formed by 18 sessions, and here we got the love health scale. Here, just a moment here. The love health scales, okay? Here's the degrees. So the patient starts the therapy, the group therapy, and they were asked, how do you see your love? If you are a healthy lover or if you're a pathological lover, how can you put yourself in the degrees? 0 degree, 10 degrees, so 0, you are 0 in love. And if you're 100, you are okay, you are healthy about your love and how you can manage your relationship, your love relationships. So here, the patients started with 0 degrees, 20 degrees, and 5 degrees. So they consider themselves just like, I'm not good to be in a relationship. I dedicate myself to the partners, but I don't like to be like that. And after our treatment, they start to see themselves like 90 degrees, 80 degrees, 70. So they get better with our psychodrama techniques, just like put yourself in the partner's shoes. So identify how you can be fulfilled by yourself, not fulfilled by the others. And when you use cognitive behavior therapy, you used to say that excessive jealousy are based in part of faulty or unhelpful ways of thinking, unlearned patterns of unhelpful behavior, so patients can learn better ways of coping with them with cognitive restructuring. So what do they do? What the patients do during the treatment? They learn to recognize distortions in thinking. They learn to develop a great sense of confidence, and they use one of our main techniques is the role playing, so the patients can see the situation and act in the situation during the therapy, so they can generalize this knowledge to the real situations. So, thank you very much. I hope you enjoy the pathologicals of love.
Okay, now we have time for some questions, discussion.
Thank you for your presentations. I've got two questions. The first one is about schizophrenia. I was thinking about how artistic behavior and an artistic trait is related to schizophrenia. And generally, it's think that this kind of strategy is related to high risk, high reward strategy. So what are your thoughts on how schizophrenia and artistic endeavor represent this high risk strategy when it goes sideways?
That's a very good question. I'm actually no specialist on schizophrenia, but there is some research about the association with schizotypical traits and creativity. So, and specifically visual creativity, right? There are many types of creativity. We were talking about musicality before, but it seems that schizophrenia is kind of specific for visual creativity and arts. I included into my presentation all these paintings that I included in my presentation were actually made by schizophrenic artists, and they are really disturbing and beautiful, right? So yeah, there is some research about creativity specifically in schizophrenic people, and that's why, and it seems actually that it's really higher, right? That there's scoring, but I mean, not in all schizophrenic patients, of course. And it seems that it might even have the same genetic base, right? The visual part of creativity and this part of like delusions or hallucinations that are often visual. Not always, right? Some delusions actually be auditory as well, and they are maybe even more frequent. But yeah, so actually based on this research or based on these evidence, some authors simply suggested that that creativity might be connected to schizophrenia, or at least to the schizotypic characteristics. And what was the second part of your question? I already forget it.
It's about a high risk, high reward strategy for surviving and to reproduce.
Yes. So this is actually, there is also one hypothesis actually trying to explain schizophrenia, that it might be basically a fast life history strategy and high risk survival and reproducing strategy. Right? There is not much evidence supporting this claim, but it's also actually quite hard to test. But it is an interesting hypothesis. Yeah. But I don't know exactly about any evidence that would really support this hypothesis. Okay.
Hello. This question is for Andrea. So as you're administering this kind of therapeutic intervention, how often does it happen that it's revealed that one partner is actually cheating on the other, and it turns out their excessive jealousy wasn't actually excessive?
Actually, is excessive jealousy. It's what determines if it's excessive or not excessive jealousy is not if you are cheated or not. No, if you're or betrayed or not, is the way that you behave yourself in front of this kind of cheat and this kind of betrayal. So if you start to stalk your partner, control your partner, this kind of, if you have a lot of intrusive thoughts about infidelity, so this characterize the excessive jealousy, independent if you are betrayed or not.
So what do you do when, has that happened, that the partners in this exchange, they find out that cheating has happened?
We used to get to resolve the problems. So, okay, it's a real problem, you are betrayed, so what are you going to do about that. We are going to continue the relationship, or you want to finish the relationship. And if you choose to terminate the relationship, how can you do? What the next steps? So we used to do like, okay, you have to take care of the children, the financial things, the things that I have on car, apartment, so who keeps the other? So like solving problems. It's a real problem, so there are a lot of steps to do. And there's a lot of frustration, sadness, and even in the therapy, we can do support for this.
Makes sense, thank you.
Well, this is for Hermano. Just if you could elaborate some more on that model you mentioned, the ACIDA model, right? And how it applies to the study of that concept of impulsivity.
Well, the ACIDA model is pretty much a clinical model. So it's meant to organize your therapeutic approach, right? Because someone comes to you and he or she will say, you know, my life is a mess. I don't control anything. I don't know where to start from. I have so many problems. I want to, let's say, I want to go to bed early so I can wake up early as well. And I will have time to work out a little bit, to have some, to have some exercising. And then I can start treating myself better. Then I will get to breakfast and I will eat all healthy stuff. Well, that's what I want to do. What really happens is I get home, I have a binge watching on Netflix. I go to bed 4 a.m. I wake up 2 p.m. I feed on whatever is on the fridge, and what is on the fridge is not really good for me, and that's my real life. So where are you going to start, right? Why is this person making so many bad decisions, one after the other, right? Is it because he or she sees food as comfort, because he's anxious and he needs something to help her deal with this this anguish feeling? Well, then you will put some. I make the play. I say, let's make the play of giving points, right? So if you think that the case with this patient is a problem of affect regulation, then you give it 3 points to that. Now, you know what? Affection regulation or affect deregulation is really there, but it's not the main core. This is not the core of the problem, really. I think he is more of a bad planner. He doesn't have self-organizing skills. So then we will give it not 3 points on A. You will give, say, 2 points on C, cognition. Right? So then you go on scoring each dimension, and then you will have set the priorities for intervention, for psychosocial intervention, for medical, for pharmacological intervention. That helps you building the plan, the therapeutic plan. We've been working on this for really 20 years. We have a psychometric model, and we hope to come up with a scale, hopefully, next year. I've been saying this for the last 5 years, okay, but so that more than just ask and build build an impression inside yourself, you could just give the patient, can you fill in this sheet with 20 questions? So say 4 questions for each dimension, And then you will say, okay, your problem is your appetites are so strong that they will overcome whatever plan or feelings you have about your life, etc. So then you can start targeting what's most important for that specific patient. Did I answer it? Okay.
Falando demais. Eu acho que vocês estão ótimos. A ideia de colocar a sua meta como terapeutas e outros. Huh? Ah, I'm sorry. And I have to recognize that I think you're acting properly by putting as your main objective increasing the well-being of your patients and of other people, and I think that's the most important thing. I have just two questions that I think might be useful at some point or another. And the first point I'd like to make is that the word sick, I've heard people sometimes find it paradoxical. They call it paradoxical, that psychiatrists don't have too much trouble diagnosing, say, autistic spectrum or schizophrenia tendencies or whatever, but they have a lot of trouble defining what's sick and what's not. And I would like to point out that I don't think that's paradoxical at all, because defining something as sick is saying something about what ought to be, or rather what not ought to be. And diagnosing someone as schizophrenic is a question of what is, not of what ought to be. And I lectured about that yesterday, I guess. And so I just think that that's something to keep in mind, that if you're questioning something, how do you decide if something is sick, then you have to go to the question of, does it bring about well-being? Is it? You have to make the distinction between what is and what ought to be. And the second question is just a question more about data. I remember seeing once that more religious people are more likely to have relatives who are schizophrenic. Is there any more data on that?
Thank you, Dennis. Yeah, the first comment is actually quite interesting. Actually, I would like to hear your opinion as well about the diagnostics. I was actually mentioning a little bit the criteria of normality, what is actually sick and what is not sick, right? What is normal, what is not normal. But I don't know, maybe actually you can tell us much better how are the diagnostic criteria, how you actually diagnose when there is a real problem, right? Because sometimes, as far as I know, it can be subjective, right? If the person actually has a subjective problem, it disturbs their life or life of other people, such as the partners, then it might be a problem, right? But yeah, it's subjective. I don't know. I would actually like to hear more about the diagnostic criteria. Do you want to talk about it a little bit?
About love and jealousy, we had when the person start to have a lot of impulsion to stalker the partner. There's a lot of damage in the social life, in the marital life. There are comorbidities associated. When they start to have intrusive thoughts, a lot of intrusive thoughts, like in the jealous person, they used to spend 10, 15 hours of the day thinking about the partner, raise the partner. So there's a kind of criteria. So in the once in a lifetime, you had a time of your jealousy, but you're not excessive jealous because you don't spend all day, almost your day, thinking about the partner. And there are a lot of thinking, just like if he isn't with me, I'm gonna die. Okay, he's not with me, and that's okay. I'll find another person. And in our clinic, you used to use scales to distinguish between normal and pathological.
About classifications in psychiatry and defining what is a disorder, what's not. First of all, we don't deal with the idea of sick or sickness, although it's a very, very valuable concept. I know that it has been explored in anthropology, for instance, as a culturally built concept that guards or not some relationship with what really is going on the body, right? But it's, in a sense, socially construed. In medicine, because psychiatry is still medicine, we talk about diseases, or we talk about, diseases, not illness. Illness will, again, run in the direction of, something socially construed. Well, but even for in the mental field, it's really hard to establish what is disordered or pathological, really. For instance, impulsive, intermittent explosive disorder. It's, among other things, clearly related to low central activity, low brain activity of serotonin that will provide an individual that is jumpier, that is more aggressive and intolerant to stress. So, I would say that 20,000 years ago, it would be just a nice thing to be lower on serotonin, because it would be more attempt in an environment that was so much more aggressive and threatening than the one we have today. Then, IED today is a problem. IED in the past would be an asset, really. So, sometimes what we call a disorder in psychiatry, I really believe that they are more like his residues, evolutionary residues that we are dealing nowadays, right? Today it's good to have a lot of serotonin so you can be more tolerant, so you don't jump into conclusions and you just start smacking people on their faces, right? Just because they could be threatening to you. Another thing is that in psychiatry, we rarely see diseases such as Alzheimer's disease. We talk of disorders because we don't know their origins. We can't explain how they are built. What's their ethiopathogeny. And another thing is that psychiatry really is sort of, it is medicine, but it's medicine's bastard son or daughter, whatever. Bastard progeny. Because for a lot of conditions in medicine in general, you know the cause, and the cause defines the disease. So this is a viral infection. Why? Because there's a virus. But what is depression really? What is anxiety? As Yarka said brilliantly, anxiety is really a heightened threat identification system working too much for a given situation. Again, this could be really useful, say, 200 years ago, right? So, it's not about building really, by now we all serious psychiatrists know that it's not about building diagnostic categories because they don't work. What we will have to is start, we've been thinking a lot about this a lot, but we haven't come out with a better solution. So the categorical model remains as much as we don't have a better model. And the better model will be one that we have dimensions of human behavior, dimensions that we can somehow correlate with brain circuitries. And then you will say, in this dimension, I'm low, I'm medium, or I'm high. And being low, medium, or high is not a problem per se, but let's say I'm low in a situation, on an environmental, on a social milieu, where being low is very good, or is not really working for me. And then we will start. So it's more than about time, and this is really not my proposition. This has been a huge discussion in psychiatry, that we are still waiting for the dimensional model. Okay? But we don't have where to cut nature in its joints. In a way, we don't really know where one dimension starts, where it ends, and when another dimension is there. And remembering that, also in a perfect dimensional model, there shouldn't be any diagonality between dimensions. They shouldn't cross each other, right? So what you see in one dimension, you won't see in the other, although they will work in parallel. So, well, it gets complicated.
So, I think you have one more question? Bruno. Oh, there.
I would like to ask you about impulsive, because we have a lot of different kind of configuration of environment. And you have this unpredictable environment. And those who live in that environment, they face a lot of lack of resources, basic resources to live and survive. Like food, even food. This is common in Brazil. Food and lack of attachment, affect, and they face a lot of challenge, like being sexual abuse, physical abuse. Anyway, it's like for me, being a little bit impulsive maybe enhance your chance of survivor and reproduce in this kind of environment, because you don't have much time to think about, and you don't have the resource, and when the resource appear is your chance, and you need to get right now. And of course the chance came with a lot of risk, so but it's your chance, so what to do. So, and for me, it's like maybe impulsive enhance this chance of survival in this kind of environment. But I'd like to hear you. Thank you.
I really liked this suggestion. I think for me, it makes completely sense, right? That in unpredictable environments, actually these fast decisions and actually low self-control can be an adaptive response, right? But of course, in other kinds of environments, this would be more problematic, and it can be really pathological. Now, my question would be, if I don't know, right, if there is any evidence, any comparative evidence, if there is probably higher incidence or higher frequency of impulse control disorders in countries with higher unpredictability, or in individuals who actually grew up in more unpredictable social and socioeconomic conditions, right? That would be my hypothesis, but I don't know if it was already tested.
Actually, there is, and I totally agree with your observation. First of all, it's good to remember that impulsivity is larger than clinics. So, because we are clinicians and researchers, but most of all clinicians, Andrea and myself, we deal with the dark side of impulsivity. But there's also a positive side to impulsivity. The positive side would be spontaneity. The positive side would be fast responses when fast responses are needed. Another, creativity, a certain healthy disregard for tradition. All this could be helpful depending on the moment and the environment. Most of all, when you're talking about people who are facing a lot of adversities, what comes to my mind is a model that is called DOHAD, Development of Health and Diseases Model. And it's all about epigenetics and all about all about fetal programming. So let's say you have a crack mom. So this woman, usually a girl, 16, 17 years old, is living on the street and smoking crack and selling her body to survive. Unfortunately, she gets pregnant, and she will endure her pregnancy in this awfully, awfully aggressive environment. Cortisol will rise, adrenaline will rise. Cortisol and adrenaline will go through the placenta and will inform the new forming brain. What will it inform? It will say this: beware, the world out there is a mess. So this baby will be already born with a heightened threat detection system from the hypothalamus to the hypophysis to the pituitary gland to the adrenal, to the como é que é? Suprarrenal? Suprarenal? No. Well, the gland that produces cortisol and adrenaline again. So this infant is likely to be very, very impulsive, meaning that he or she will engage earlier in a lot of risk behaviors, and that includes unsafe sex. That includes increasing their possibility of reproducing before death comes, because death is a likelier possibility in such dangerous environments. And that's the perpetuation of impulsivity. So yes, in terms of surviving, depending on the environment, impulsivity could be very desirable, or at least could be useful.
So I think we need to finish because coffee break is already waiting for us, I guess. So thank you again that you joined this very interesting symposium. It's always very interesting to hear about your practice and about your experience, which is really great and very relevant for this Congress. And yeah, I think that actually you were speaking about pathological love, pathological jealousy. You are also working with pathological gaming, right? So that there is actually lots of areas that they are working on, and they have so many patients that they are almost unable to attend them. So this actually shows perfectly that people are unable to control themselves. So thank you very much for your attention. We will have a coffee break now, and then we will come back to have the last session of today. Thank you.